this is really pretty exciting for us to pull together our fellows, to know that we have some fellows that have already graduated and are practicing and teaching. And it comes because of people like Miriam, who has revolutionized the IRF, and Tom and Hannah, changing the whole educational process so that it's much more of an educational experience, and Emmy bringing this forward. So there's a lot of people to thank to pull this together, especially Miriam. So thank you all. So I'm grinning ear to ear today because two of the coolest people I know have volunteered to join up with us, John Melvin and Paul Clyde. John was my mentor, which makes him kind of old, but not that old, and is probably the most influential rehab doctor of his generation in the world. That is not hyperbole. Been president of everything. And what I noticed when John stopped being president of the societies, they call him into the meeting, they all talk, and then they say, John, what do you think? And then they do what John says. So he started out as a real live scientist and a real live clinician, and has become one of the great leaders in the world in our field. And John, if I can, let's give you maybe about 10 minutes to kind of just describe where you're from and what you're about and what interests you have.
Okay, well, as you probably know, I'm retired now, and my interest is to do things like this free, just like Tom does. I thought I would share some experiences just to show you where I come from. I actually have been around in PM&R for a long time. I started my residency in 1961, and I finished the residency in 66 and started on the faculty at Ohio State. And I was a faculty member, an active working faculty member until 2017. And from 73 to 2016, I was in charge of the clinical services, including the inpatient services. But one reason I say how long, and I'm not trying to say I'm an old person, but so much as to say that I've been around a long time and I've observed a lot that's gone on. And we think about the US, being a hotbed of rehabilitation, but when I started, it was not that well accepted a field. There were some nice, good centers, and there were a lot of places where there was absolutely nothing. And so we always called ourselves proselytizers because we were selling rehabilitation. We were advocates for rehabilitation. And for instance, even during my residency, I would be giving lectures to various professional groups. What is rehabilitation? And including medical societies, nursing groups, OT groups, all kinds of different groups. So we were involved, and I've been involved all my life now, in a lot of advocacy. Now, we talk about having units versus treating patients in the acute hospitals. One of my first jobs actually was providing rehabilitation services to the patients in the acute rehabilitation, in the acute hospital of Ohio State University, their university hospital. The point was that at that time we had so many patients that we couldn't get them into the rehab center right when they were ready to go. And so we basically gave them a full rehabilitation program until they were able to go there. And if they got better fast, well, of course, they went straight home. And so nobody in the US knows now about doing full rehab during the acute phase, but that was a very common thing at one time. And although I was always associated with a university and a large hospital, in my first years, all the way up until 91, I did consulting at peripheral community hospitals, sometimes as far away as 30 miles from the university hospital. And that was useful because there again, there would be people in these communities who did not want to leave the community. And so if they needed rehabilitation, again, they got it in a community acute hospital. And usually one not exceptionally endowed in rehabilitation services. So it was doing what you could because that's what the patients demanded. So during my career, I basically was at 4 places: Ohio State University, the Medical College of Wisconsin, and the Milwaukee Medical Complex. Moss Rehab, which is a very advanced rehab hospital in Philadelphia, and Thomas Jefferson University. And as I pointed out, I was, for all but the first one, I was in charge of them. And I will say that they were all different challenges, and the management of them was difficult. And even though it was in a developed country, I would say that some of the principles that had to be dealt with, like doing things with restricted resources, trying to get people to be able to do the various jobs, actually carries over into the low income and middle income area. So it's not totally different. I started being involved internationally in 1980 when I became secretary of the International Federation of PM&R, and was an officer in one of the international organizations until 2004, when I finished being the past president of the International Society of Physical and Rehabilitation Medicine. And as Andy pointed out, I still am invited to all of the governance meetings. I think part of it's because I was part of the group that put together these organizations, and we wrote the bylaws and the statutes. And so one good way of controlling an organization is to know the statutes inside and out, and maybe even to be able to change them, because frequently that's what they're asking advice about. Yeah, I wrote some of this down because I wasn't sure I'd be able to remember it all. I've been active in the WHO. I did some just consulting to the director of the rehab section. And then I was a member of the advisory group for ICD-11, which is still, well, it started some places, but it's mostly not out yet. The major thing about that I like is that it has in place for adding functioning information as a part of the standard classification. I also edited 2 handbooks for mid-level health professionals, health providers, I guess the WHO calls them, one on brain injury and one on amputee. So, the focus on non-traditional specialties was there. And I authored 4 monographs on rehabilitation, also for the one core, where they were sort of like curricula, 1 core curriculum and 3 more advanced curriculum. And then I was a member of the group that submitted that technical meeting report that I distributed to all of you, that talked about making the case for rehabilitation in low and mid-level areas. So some general comments that I thought, I think I still have, what, 5 minutes or 4 or something. Anyway, I think it's important to step back in the beginning and realize that advocating for the development of rehab services is work. It takes active people, sort of enthusiastic people, and it's non-ending. I started being an advocate in, as I said, during the residency, when I was out trying to get people to understand what rehabilitation was, and I'm still doing it. And I'm still on multiple committees that are trying to get the government to do whatever we would like them to do, which sometimes we succeed and sometimes we don't. So if one decides that they really want to be an advocate, it's a major part of one's being, and it takes a certain amount of energy, sort of like an Andy Haig energy level. The issues are complex, and so it isn't like one can come up with just a simple answer. And I like to think of them as in 3 different categories. One's more technical, what's good rehab, what should be there. Financial, which is always important in these days in healthcare. And then political, and political has always been a major issue with rehabilitation and people that do rehabilitation. Essentially, the political side is who does what, and how do you allocate the resources if you take some from somebody else? How do you deal with explaining that? And I know that's behind a lot of the questions. And some strategies that I think are overall strategies is that I think that each case, each place has to analyze their own situation. There may be similarities in terms of generalities, but I think the actual reality of how to try to get something done is different each place. And so it means taking the time and effort to analyze objectively, because sometimes we get emotionally involved or subjectively, and that then distorts our ability to really read the situation and see what we can do to influence it. And I think it's important to seek out and identify the decision makers. And that has to do, again, with what kind of problem it is, and also what turns on that decision maker. If it's a legislator that's going to get elected, if he's in favor of things that are humanitarian, that's one thing. If it's a hospital administrator that worries about how much money per bed he makes per day, that's another thing. And so it's important to match that very carefully. I think that actually accepting incremental goals is often a necessary approach. My own model is I like to have my big comprehensive goal that may be 10 years, 15 years away, and then work on incremental steps to get there, having figured out how those steps relate to getting to the ultimate goal. One reason not to do that is that you can start to implement things that are helping you get to the goal that actually you have opponents who don't want you to achieve. But you can start building the framework, the foundation of getting there, so that by the time they realize what you've been doing, it's too late. And I think that what's really important of the rehab people is that they have to integrate themselves into the healthcare system. When I started out, most of the PM&R doctors were what I call basement boys. They were mostly male, or I think almost all. They were in the basement of the hospitals because they used a lot of hydrotherapy, and that's where it was more effective to put it. And they used to have contracts where they would see every patient, no matter what, that was going to get therapy, no matter what. So they would write 50 times a day, 3-point gait with cane in the right hand. The first thing I did is got rid of that when I went to Milwaukee, Andy, because I took the position that we're specialists, and so we'll wait till you ask for us to do something special. But in the meantime, you have to get out there. You have to, whatever the socialization framework of the physicians that make referrals and that you're going to collaborate with, that needs to be penetrated. It used to be the coffee room for the medical staff. I don't think that's quite so much anymore. But the point is that you've got to get out and be seen, be known as another doctor, not as, so that you are projecting that you're not just somebody doing physical therapy. You're involved in a certain type of patient, which includes adding the rehabilitation or therapy aspects that it might take. And then the final point I guess I would make is that I think that the report, the technical report of the WHO committee on looking for the case report has some really good pieces to it. And I think that one should really kind of get to know, particularly I thought the part on challenges and issues that are on pages 14 and 15, and then table 3, which are the benefits of rehab. So that's my introduction.
Fantastic. Thank you, John. Thank you. So the other great speaker is Paul Clyde, who, if you look at it from the outside, he's the guy who runs the William Davidson Institute, which is one of the world's great centers for entrepreneurial doing good, a big building in Ann Arbor. But of course, that's not what I remember. I remember wandering through Uganda with Paul and seeing this guy who's just a fantastic intuitive leader that could talk to a nurse's aide and the Minister of Health at the same level of dignity. Paul's pretty darn famous for taking apart the healthcare systems and figuring out how they can survive in some of the toughest situations. And I've always wanted to tap his brain on rehab. We did a lot of that on our trip and in some of our writing together, Paul, but I'm really delighted if you could give us a few minutes of where you're from and what you're up to in general before the fellows start quizzing you guys. That'd be great, Paul.
Well, thanks, Andy, and thanks for the introduction, which I think is at best partially warranted. But let me make clear from the beginning that rehab is not, I'm not a doctor, and rehab is not my specialty. I'm an economist. And so I think about these things from a variety of different perspectives, but I noticed a lot of the questions were about getting the government involved and getting government support by it. One of the things I'd like to talk about more is engaging the private sector and the motivation, the interest from the private sector. And let me tell you, I'll tell you about my background a little bit and you'll see why. So my PhD is in economics, as I mentioned, and I started out in the US government, working with the Department of Justice and the Antitrust Division on mergers and acquisitions. And as part of that, we would do a lot of cost benefit analysis of the kind of, and the type of thing that you're talking about here. What's the benefit of rehab? So we would analyze some policy questions from that perspective. But as part of that, I lived in Slovakia for a year in 1993 and was working with the Czech and Slovak governments. And I came back from that convinced that we could have perfect policy on these things, but unless the private sector was really thriving, we weren't going to see the transition of these economies that we were hoping for. And so I still wasn't really focused on healthcare at that point, but I was, throughout my career, I've been focused on low and middle income countries. And what it used to be transition and developing economies, and then it moved into emerging economies. And now the trend seems to be to refer to them as low and middle income countries. But the same kind of thought process was going on through all of that. And when I came back, I learned about this institute called the William Davidson Institute that was really, in my view, unique at the time in that it was focused on the private sector. So this was WDI was established in 1992, and it was established by a fellow named Bill Davidson, who said the mission of it was to equip economic decision makers in emerging countries with the tools of commercial success. And so he's very much focused on the business aspect of it. And today that's not that unusual, but when I was working in this field in the early 90s, the vast majority of the work that was going on was at the policy level. It was at the government level. It wasn't thinking about the private sector and the development of the private sector. So that really caught my attention, and I moved to Ann Arbor from Washington, D.C. In 1997 and have been on the faculty at Ross, at the Ross School of Business since then, and worked with WDI from the very beginning. And then in 2014, I moved over permanently. So I still have a joint appointment. I still have an appointment at Ross, but my primary job is at the William Davidson Institute, as Andy mentioned. And we have 4 areas that we focus on there, one of which is healthcare. And so we're focused on the business of healthcare. So that sort of is the background from that perspective. On the healthcare side, my first interaction with that was with someone who's become a good friend of mine named Dr. Aravind, who is in India. And it's relevant for this because, so Dr. Aravind is part of the Aravind Eye Hospital, which you may or may not have heard of. It's by some measures the largest eye hospital in the world. It's got a series of different eye hospitals in southern India, Tamil Nadu primarily. Also does a lot of consulting. And I met Dr. Aravind when he was getting his MBA at Michigan in 1999. And he was telling me what they did. And at the time, it was primarily cataract surgeries. And they offered about 70% of them for free, and they charged for the other 30%. And they were able to cover all their costs. And this was really striking to me because there was a lot I had seen things going on in global health, but most of it was looking for outside funding of some sort. And they didn't need any outside funding. They were able to completely sustain their business through their own internal operations. And I bring that up because that model had a lasting impact on me. I still remember exactly where I was when he was telling me about this, because I had spent quite a few years in development economics, and I'd never heard of a model like this. And I have since learned that it really is an amazing one. Dr. Aravind himself he's got an enormous amount of energy. He's more than I do, probably at Andy's level, and he started his own rehabilitation facility in 2010. And so for about the last 10 years, he's had this organization called Live Well that he started, in addition to his main job, which is running one of the largest physical hospital in the RF system and being on the leadership team of that. And he is an ophthalmologist, so he didn't change his medical training, but he started up this rehabilitation facility with much of the same model, where he's got paying patients coming in there, and they support, he's able to cover all of his costs through what he does. And in India at the time, there were very few, if any. I mean, I'll let you all know more about this than I, but my understanding from him was finding a PM&R doctor in India was virtually impossible. CMC Vellore, I think, was doing some training of them, but I believe it was the only one in India that was training any of them. You, again, would know more than I on that, but I just know he had trouble finding one. And today, his rehabilitation facility was unusual at the time. And today, there are a number of them in India, and it's grown significantly for a variety of reasons. There's been a demand there. But that was my first interaction on the healthcare side. And then after that, in about 2005, 2006, we started working with hospitals, first in Uganda, and now we work with hospitals or clinics or healthcare providers of one sort or another, everywhere from Ethiopia, Uganda, Kenya, India, Sri Lanka, Senegal. We're in a variety of different places, and we use student teams, MBA teams of MBA students who are on average, 29 or 30 years old, so they've had some work experience, and they'll go out and do consulting projects. And we have our own staff at WDI, but when I use student teams, I'm able to do that at very low cost, or basically the healthcare provider just provides them the team with housing when they're there for the 2 to 4 weeks that they're there. And then the team will come up with whatever consulting project the hospital has asked for. And we've done over 100 of those projects over the past 20 years, many with Arvin, but many with these other hospitals. And so that sort of is where I've been focused, and really focused on the business model side of things, of how can you provide healthcare in these markets and cover your costs at the same time. And sometimes it's a cross subsidy model that you have a group of patients that you're charging and you're cross subsidizing that. Andy mentioned the one around Uganda. That's what we were looking at there. And we actually made it fairly far down the path there. And there is a doctor there, an orthopedic surgeon who we worked with quite closely and who still has a practice that's thriving there. And I think the possibilities on that front are enormous, and we can talk about those a little bit more later on. But that's sort of a brief background on me and my interaction in the healthcare side of it and where I'm coming from.
Thanks, Paul. I get pretty excited thinking that we might be able to do the math and succeed for our doctors who are not trained in what you do. Sinforian sent us a text that it's raining hard there. We probably should have him go first. Welcome to our classes. Sinforian, if you're ready, why don't you have a conversation with these two experts then?
Okay, thank you, Dr. Heg, for giving me the floor. It's a great privilege for me to speak to our great speaker today, and it's a great honor as a IRF fellow. Okay, I have 3 questions for the two speakers. Am I supposed to deliver all the questions, or just one question and the rest before?
I think, Sinforian, with your questions in your mind, you can just have a conversation with our experts. Talk about things and follow up as you wish.
Okay, thank you. Please, I would like to know the first question. The first things that I would like to say is just in our countries, sub-Saharan African countries, for example, rehabilitation is not almost funded, and I would like to know what advice can you give us just to improve that situation, because most of the time the policymakers don't put a lot of money to invest in rehabilitation, even though in rehab facilities and the recruitment or the employment of rehab professional. What do we think about that? How can we do to improve that situation?
Oh, so I'm interpreting the question as to how to expand the awareness of rehabilitation. And if I think I heard you speak, I think you mentioned the government. I mean,
Yes, of course.
and also the other doctors. Was that in there? So go ahead.
Okay, it was about the policymakers, so the government authorities. How can we do to make them invest more in rehabilitation? That's the question, sir.
Well, of course, it depends a little bit on exactly what part of the government you're talking about. There would be agencies often that are responsible for the rehabilitation or for the healthcare area. So that might be one group. The people, if you're in a country that elects their representatives that approve the budgets of the government, then you may have that group to look at. What we've done basically is we establish on a long-term basis organizations that provide regularly information to these parts of the government within the context of what their responsibility is. So one may be putting together rules and regulations, another may be allocating resources, another may be just voting for things. And so it becomes first important to recognize who are the decision makers, who are the ones that might be able to control from the government perspective resources, and then consistent with their role, establish a communication about what are the benefits of rehabilitation. And again, I think you want to look at the benefits as being not just humanitarian, although that's an important one, but also the financial benefits that it brings to hospitals. For instance, not having patients jammed up in an acute hospital because there's a place to get them out. And you also, at that level, at the government level, you may want to be even being more macroeconomics about the way in which if you have people go home more independent, they don't require the caregiver that was in the home that was working outside the home. And so that's dealing with employment and other kinds of things. And that's why I say that list is a good list, because it's a long one and it goes through a lot of different things of that nature.
Okay, so thank you.
Yeah.
Thank you. I think okay.
Can I add something to it? So I think what John was suggesting on looking at all the costs that are foregone that as a result of the care that's exactly right. That's when I was in government, that's exactly how we would go about looking at the cost benefit analysis of any activity. What is it that is the cost, the counterfactual? What's the cost of doing it this way and the benefit of doing it this way versus the alternative, the next best alternative that's out there? But I would go back to something I mentioned in the introduction. I would think about the private sector as a way to start this out. And if you do that, and let me say, I got your questions early on, and thanks for sending them. So I'm sort of looking at what you were asking as well, and in the written questions. But I would think about who is it going to benefit privately too. So from the government's perspective, they've got their cost structure that they've got to cover. And so if you can show them that this is a lower cost way of serving the constituency or doing something else that you're already doing, that's going to be appealing to them at some level. But when you're talking with government, there are a lot of politics involved. There are a lot of other factors that come into play that can complicate the situation. If you're doing it on the private sector side, you're looking at who is it that we're providing value to and how are we providing value? And so for instance, when I've looked at this with Rehab in particular, we went and looked at some companies out there. So this was in Uganda, and we had some conversations with some companies who had employees who had there was a lot of physical activity involved in it. And so they would get hurt. And if they did get hurt, they were all of a sudden out of work for a significant period of time. And their only alternative for getting treatment, whether it was clinical treatment or physiotherapy treatment, was to go to a facility that was a couple hours away. And so the position we were taking is, if there's a facility that's right here, you can have the patient treated, the worker treated more quickly, and be able to get back to work more quickly. And that's to the benefit of your bottom line. So even in cases, the first group would be the patient themselves. The patient themselves may be willing to pay. And in many of, so I noticed Ethiopia and Ghana were mentioned, and about 50% of the payments come from our private, either out of pocket or prepaid private expenditures in those countries, 50% of the total healthcare expenditures. And in some countries, it's even higher than that. So it's not an insignificant amount of payment that's coming out. And then you figure out, all right, how do I make an argument to those who would pay? And you could go to the individual themselves, or you could go to the companies that are employing those individuals. Now, that's not at the country level, but if you can make the case to them, you might be able to put together something that looks like an insurance plan or a prepayment plan that is specific, that their staff has access to these services in that location. And the other benefit of that is that in doing so, you've developed a pilot study that you can effectively then take to the government and say, see how this worked here, see how effective it was, and try to encourage the government to do it. But the part of the reason I become more focused on the private sector, having been in government and having worked with foreign governments, is that seems like the quicker way to get things done. You're able to take important steps more quickly through those. And it doesn't need to be an either or. It can be in combination with working with the government and engaging the government as well. But it can be an important avenue for getting to both of them.
Okay.
So
Could I comment on, I agree with that very much. The idea is to try to get an island going, and looking for places where that could happen. And that relates to the more broad question, I think somewhere was, how do we get people to know about rehab? So you get it going where you can. And if you can do just what Paul's outlined, which is a very good idea of looking at a company, for instance, that has a need. And so now you've found something that you're going to be solving a problem with. And while it may be only a small part, and maybe it doesn't take care of all the poor people, and initially, it at least gets an island going where people understand that rehabilitation has good effects and cost-effective effects.
Thanks. I'm going to be the time police, but not to our faculty, just to our fellows. And both of you, by the way, the South African friends who are lurking in the background, and I had that very discussion. Thank you. Just this morning. Sena in Ethiopia, she's actually the director of the family medicine residency and is our fellow as well. Sena, are you ready to ask a question or two?
Sure, definitely. Can you hear me?
Yes.
Yes.
Yeah, thank you so much. I'm Sena from Ethiopia, and for me it's a great pleasure to be in this forum, and I have a lot of issues to ask, but I will be very specific, and I will point just one question for a time being. My question is, as you know, in Ethiopia, especially at our center, we don't have like 3 physiatrists. I am one fellow, and we do not have occupational therapist, speech therapist, and rehab nurse. And we are planning of having a rehab center, but we do not have this professional. So especially for Dr. John, I want to know, and I really want to ask you that, how can we start without having these professionals? Is it really practical and feasible to have a rehab unit without having these professionals? What is your experiences? Thank you so much.
Well, I think the first step is that it's defined by the patients. So if you have patients that have special needs for improving function, the idea of having a place for them is a good idea, and your ability in terms of either having people available or the resources to provide the typical Western model may not be there, but the idea of trying to deal with the subsets of issues of occupational health or occupational therapy and or speech therapy, one may want to see if there's a possibility of having less than fully trained certified people who work at a lesser level in the same areas. So, a lot of occupational therapy is common sense in terms of trying to develop ways for people to adapt to their disability and yet be able to take care of themselves in terms of dressing and other forms of self-care. So I think that I would be searching for surrogates in those areas that would, the ideal would be that they would be able to go somewhere and get some special training. But it might be that the rehab physician leading the group would have to try to make the situation work as well as it can. But I think it's still good to have people who are focused on the needs of the patients, even if you can't have the full Western model.
The other thing I would add, something I think I learned from Andy, is that, if I'm reading the question that was sent earlier, and if I'm understanding it correctly, it seems to me like the bulk of the benefit is going to come from the first step. So even if you only have a physical rehabilitation and don't have the occupational therapy and the speech therapy, it seems like there could be a huge marginal incremental benefit from that by itself, and then add on, and John's idea of, trying to use other surrogates for it, it would be a really nice complement to it. But even if you couldn't have it, my sense from Andy and also at LiveWell, because I don't think they did not have those when they started up, but they were able to provide a lot of value to the people in their community just with whatever services they were able to provide.
Yeah, and I would agree with that too. The only point I would make though is that in some areas actually the physical therapists then start to develop some skill sets that would be also in the usual occupational therapy. So I think the key is to not restrict the vision of the rehabilitation to just motor walking and transfers, and strength, but to also correlate that with activities that are needed to be done because you have it.
Did we lose Sina?
Okay, thank you so much. I have one more question. For the other question is, as you know, in Africa, especially in Ethiopia, it's really very difficult even to address emergency cases, as you know, because of the poor healthcare system, because of poor infrastructure and so on. So how can I go and convince like the Ministry of Health and also the politicians? How can I convince them to have rehab centers? What is your experience? Like sometimes we take other countries' experience. What do they get? What do they benefit? Like, I just want to know these things. Thank you. Economic impact of rehabilitation and so on.
So I'm trying to understand, it is that the resources for healthcare are so low that even emergency care is not provided. Is that, and so now we're wondering how we also get some for rehab?
Yes.
Yeah. Well, there, I think part of it would have to be that the rehabilitation doctor, first of all, the rehabilitation doctor can do a lot themselves. So, and as I mentioned before, we used to do a lot for the patients that were in the acute hospital. So having a separate center necessarily may not be feasible. But I think that it's important to have a broad vision of the healthcare in one's area, and to be sure that that one doesn't sort of seem in the position of demanding or soliciting resources when something else that is critical might be restricted from them. And I have to give you an example of once I was a consultant in Cyprus, and the issue was how to improve their spinal cord injury care. And ultimately, our advice was that they needed a better emergency evacuation system so that they didn't convert every case to full thickness spinal injury. If they were going to only put some resources there. So I think that the context is, one can take the point of view that a lot of acute care needs rehabilitation in order for it to be given effectively, economically, as well as far as outcomes. But if you're just absolutely down to zero, then I think it's probably important to look to see where it is, and most important, in the healthcare system.
So, see, can I ask, where are you at St. Paul's, or what are you affiliated with there?
Yes, I'm at St. Paul.
St. Paul. Okay, so yeah, we've done quite a. University of Michigan has a fairly close relationship in general with St. Paul, especially on the clinical side. But I know that, you know, I'm gonna sound like a broken record, but I know that there are a number of private efforts that are taking place there successfully. In fact, we're working with someone right now who is starting up it's going to be sort of a home service clinical care, but it would include rehabilitation, and he's very clear about including something like that in it. And there's another hospital, Ethio-American Doctors Group, that's starting up there. They broke ground and they're building one. There's a Korean hospital there. There are a number of efforts that even if you can't convince the government, so this one who's starting up the home care already has a private organization that offers diagnostic services. And he is a licensed dealer for some of the major diagnostic equipment, but he also offers the services themselves for hospitals that cannot afford to buy the diagnostic equipment. And he's doing this completely as a private entity. He's not convincing the government of anything. He's doing it and providing the service to the local hospitals and to the local patients. And it seems to me that Ethiopia, from what the interactions I've had with companies there, is really the advances that are taking place in the healthcare are significant, and it's a great environment to be in, to trying something new and starting it up. And again, if you're able to succeed, you know, as John described it, as an island, if you can get an island going and use that as an example to take to the Ministry of Health and to other government officials, because I know the Ministry of Education also has a role. I think they're the ones that are the governing body of St. Paul's. But you can use that as evidence, and then maybe have that roll over into some of the government institutions. But the opportunities on the private side seem to be significant, and I know of a number that have been quite successful there in Ethiopia.
Yeah, I think Paul's point is a very good one. To me, what it is it's an example of analyzing the whole situation in a global way and looking for where the potential opportunities are, and then going for where you see the easier place to go if it's possible.
I should say, as I transition us, I've gotten a couple of texts from our friends in Africa who are just absolutely agreeing with you folks about if you can get it out of government. And the challenge, of course, is to get the training out of government. I'm going to transition, though, because I'm going to try to keep us all on some kind of time frame. Benedict is in Ghana, and if you're ready, Benedict, introduce yourself and start up with some of your thoughts. Are we there something? Benedict?
Thank you, Andy, for letting me in, and it's been good.
Bad connection.
Listening to. Hello.
Yes. Okay.
Yes. Hello. Yes. Thanks to our speakers. It's been interesting listening to the great insights they're sharing. I want to go back to the government side because I'm a government person. I head a public hospital, and then I also see to the leprosy program in my country. So very much a public health system person, and it's good to see the examples of leveraging the interest from the private sector to build up psychiatry in any country. But I want to go back there again, because in my peculiar situation, I would have to make a business case for PMR in the public sector. I really need to do that, and not just with the infrastructure. When I was in my training period, I were part of a project to try and introduce palliative care services, and what I realized is that although people were ready to pay, many times, because the patients were coming from primary care, and my primary specialty is family medicine, a lot of people who required the services couldn't pay, and we spent a whole lot of time trying to convince the insurance scheme to take it up, and it never happened. What I want to ask is, do you have any experience building a business case for PMR to governments? And do you have any tips for us as to how to go about that? Thank you.
Paul, do you want to go with anything besides private?
Well, so I mean, as I said earlier, I was involved on the government side, not on physical medicine and rehabilitation, but on doing assessments, and the analysis is not significantly different, because I mean, in your question, the one that you sent, you were asking something about the cost structure and the financing and both the financing of the physical assets and the financing from the patients. So there's one distinction I would make is the financing that the organization needs to start this up, which is going to be to pay for the fixed assets and the employment costs and so on and so forth. And then on the revenue side for them is the cost to the patients. And we have done, I think some of these things are intertwined. In Ghana, we've been working with something on payment models using telecom, and it has been in conjunction with the government, but trying to make the payment process easier. That doesn't necessarily address if the patient doesn't have the money to do it, but there are things that can be done to lower the overall cost structure of everything involved in it, which will make it more inviting to a government. But the basic argument you're going to have to be making to government is the same kind of cost benefit analysis you're going to have to make to any investor. And that is that the amount of money you're investing in this capital equipment, the working costs, the entire doing a whole pro forma income statement going forward is going to have to be warranted by the benefit that's coming out of it. And the one, in some sense, a government, there are all sorts of challenges with governments, which is part of the reason we shy away from it. It's also not our mission. But there is a good side of the government, is that they are going to be they should be ideally moved by social benefits and social, the benefits that come out of it that aren't directly reductions in cost, like an employee being more available or something like that. It could be that the overall welfare of the society, or the fact that people's lives they are able to live their lives in a better way. And because the government isn't having to spend as much money on the follow-up care for people that are needing the rehabilitation, because the rehabilitation gets them to a point that they're able to care for themselves more. All of those benefits are going to show up on the government side that would not necessarily be on the private side. So that is something to keep in mind. But I think the basic cost benefit analysis is going to be largely the same. I can't speak specifically to doing this in PM&R though.
So Karen, following up on that, there are a lot of places where, if you look at the model of a healthcare delivery, that if you have good rehabilitation services, that it reduces costs on the acute side. For instance, a certain number of patients will be discharged earlier from the acute hospital because they got rehabilitation. And so you're saving on the number of acute beds there. As Paul talked about, you're less likely to have readmissions because of people developing new problems. And then there are the other social benefits such as I mentioned earlier, a wife who's employed won't have to stay home and take care of the husband who's still having problems. And again, I refer you back to that list of benefits of rehabilitation, because there are a large number of these kinds of things there that one, I think, could capture and put together into a presentation to the government.
Thank you. Thank you. Thanks.
Benedict, any follow-up?
Yes. No, I think not now. I think the directions they pointed to are enough for now. But I have another question, if I could ask.
Yes.
Yes. And that is a little bit away from the business side of things, more to do with the awareness side. Looking at a situation where other therapists in the PMR world are probably well known to medical colleagues than physiatrists, and even for me, sometimes I've had people say, "Oh, so you're doing that physiotherapy thing," you know. And when you want to get involved, is like, okay, this person needs to be referred to PT, you know. And how will you suggest? Do you have any tips how we can gain visibility amongst our very own? You know, yes, we will be doing something which has great benefits, but I realize that it would take concerted action to get the attention of our colleagues. Do you have any experience with that? And can you share those tips with us, how to go about that?
Well, I've had a lot of experience with colleagues, and one of the things that I always say is that if you wait long enough, they'll come. We had, when I started out, a chairman of orthopedic surgery that could not tolerate PM&R. He saw it as a useless place until he got a bad back and he didn't want to be operated on himself. And so then he was there. And also he understood that the role of the physician is to correlate the pathophysiology to whatever the therapy is being used. And so that there's a rationale. It isn't just I'm strengthening something, but there's some reason why it was weak, and there's some body structures that are involved, and there are treatments, many of which are medical, that are also involved. And so, as I mentioned earlier, one should do whatever one can do to be very visible to the other physicians, particularly those that might be potential referring sources, even to the point of becoming their friends. And then through discussions and these interactions, you can let them know how you look at some of these problems, which are beyond just the mechanics of conditioning and exercise and technique, but it's really the correlation of the medical part to it. You know, I don't know how many times I used to have patients that went to the therapist and they were getting one form of back exercise, which happened to be aggravating them because they were, you know, closing their foramina, for instance. And that's an example of where understanding the pathophysiology and then of correlating what's being done to that is important. And this is what you want your colleagues to gradually start to realize. And that's how you want, in my mind, you. So that's why you need to kind of be a beat person again a little bit in terms of them seeing you as somebody that they think is a competent, good, bright person, and then you show an interest in the kind of problem that they have, but the interest is more than just a therapy interest.
I'm going to keep moving us forward. This is so rapid fire because basically we want to lock you two guys in a room with us for 3 weeks, okay? And we can't do that. So I'm going to be the timekeeper here. But both Sinfarian and Tom have some important questions to ask after a break, but we're going to keep ourselves online here. Miriam has a next step, which is kind of a break and something for our audience to do. So go ahead, Miriam, it's up to you.
Yeah, we're gonna just take a quick break before we jump into the audience questions. If you have not joined in our Miro board, please do so. I just left another link there. Hopefully you're seeing a bunch of questions that are left here for you guys, for Paul and John. This is a time for you guys to read the questions and perhaps select one or two that you can answer. If you audience have not written your questions down, this is a moment for you guys to do it now. And if you have already done so, I'm going to zoom out here. There's also an opportunity for you guys to introduce yourself on this whiteboard here. Grab one of these Post-it notes, make it bigger, and then double click on it and write down your name, where you're from, your contact information, and what your passion is and how you got to join this webinar. And just post it on the world map here where your passion is or where you're from. We already see a couple Post-it notes here introducing themselves and about who they are and what their passion is. And at the end of the session, what I'll do is I'll collect all this information and send you guys a link to maybe potential happy hours and more connections to make in the future. So we'll give you another 3 or 4 minutes to play around in the Miro board.
Andy, can we ask some other questions? I think Symphorian had some other questions that he couldn't ask before going off.
That's right. Maybe we should do that now. I was going to give us a few minutes of not asking questions, but it's probably time. So Symphorian, I know I had you lined up to follow up on your question. Go ahead, Symphorian.
Okay.
Okay, thank you, sir. I will be very fast. Okay, I have one question with 2 ideas. I would like to know from our speakers, how can we assess the global rehabilitation country? Because in Cameroon, we
I'm sorry, but it's sort of distorted on my
rehabilitation, and I think that it is the same situation in many.
Symphorian,
I would like to know what is the I would like to know what is the good methodology to assess the global rehabilitation situation in a country, because in Cameroon, as in many other African countries, we don't have the global situation of rehabilitation. So I think that if we want to improve something, we are supposed to know where we are now and where we want to go or what we want to achieve. I think that's something which is really capital if we want to improve and to make a rehabilitation be most recognized in our country. And this leads me to one another aspect, is that it's about data collection about rehabilitation in the global health system. I think that Professor John talked about it a bit, because in our health system, we have no indicators or no data about rehabilitation. And I would like to know, how can we, what can be the strategy to put in place rehabilitation indicators in our health system data collection, and what could be the key indicators that we can try to monitor. So that's my 2 ideas. Thank you for your answers.
So I had a little trouble understanding the question. The question was how to position rehabilitation.
John, I could help because I understand. One question was, how do we measure disability as a baseline as we get going in a country? And the second is, I believe, about how the healthcare system following and measuring the global picture of functioning and disability in a country.
Well, of course, it usually means setting up some kind of data system. And of course, we're in favor of that. And it strikes me of 2 papers I've written. One is that we do need a data system on functioning in the health systems of the world, and that we can compare them. And then there's another paper that talks about what are the elements that you could look at in a given country to see how well that country is conforming to the World Health Organization mandates regarding rehabilitation. But if we're talking a little bit more mechanically, there's an initiative in a number of countries, Malaysia, Japan, China, where they're using the core sets that, again, the WHO has, and usually one of the generic ones, either the 6 or 7 generic or the 30 element generic, usually the 30 element if you're talking about rehabilitation. And these elements are, they adjust the language for the different countries so that it's culturally consistent. And they talk about it having intuitive, simple descriptions for the people that are doing it. And that what they've shown even psychometrically is that the physicians who are doing this in these countries using a simple sliding scale, either 0 to 4 or 0 to 10, are able to develop information that...
Somebody needs to mute. Oh, thank you.
I thought it was. I don't think I can kill mine. I don't know, maybe. But anyway, they just have a simple scale that they make their estimate at given moments in time. And they've shown that this has actually been beneficial in being able to make comparisons over time. And so that's what's going on in at least a number of different countries in terms of setting up a system. But you have to get some kind of central acceptance of the idea of doing that.
So I'm going off the question. I think this is the same one that we were sent earlier. And I'm also not sure I'm understanding it correctly, but the way I was interpreting it, at least, one of my thoughts would be to get a sense of what the demand for this would be is to look at the kinds of, so IHME has a database which projects that is a combination of surveys and projections of different kinds of healthcare challenges in different countries. And so, for instance, if I go back to LiveWell, a lot of their patients are stroke victims. So one thing I would do is go look at what's the number of stroke victims by country and say, I don't know what percent of them would benefit from rehabilitation, but take some percentage based on data from other countries and say, suppose it's the same percentage. That gives me some idea of the potential benefit of rehabilitation for stroke. Traffic accidents would be another one, and they track those as well. So all these different, they calculate the DALYs for each of these, the disability adjusted life years, and that would give you some measure of how prevalent the different conditions are that would benefit from rehabilitation. And you can use that. It's a very high level number, and it's going to be very inexact, but it's some way of measuring up front what's the potential benefit for this. And then in terms of gathering the data going along, in addition to what John was talking about, if I had my own hospital, I might want to be surveying my patients who received the treatment on what is it that you're able to do now that you were not able to do before, to start getting something along those lines, to get some idea of what are the kinds of benefits in this particular community that we're going to want to quantify one way or another. But that would be very specific. I mean, I'm guessing there are some generic surveys that are out there that can be used for rehabilitation, but there might be some that are very specific to that local community too, or to that hospital, where you can be using that to make the case then later on for the benefit of rehabilitation, but you can also use it for your own operations to tell you about things that you could might want to focus on more or might want to do differently. If I go back to LiveWell, when we were working on that in India, it was not anticipated that stroke victims would be such a major part of the patient population, but it ended up being that way. Now, I don't know if it was sort of feeding on itself that they had taken a few stroke patients and they got a reputation because of that, so they started getting more and more stroke patients. But for whatever reason, they did get a lot of those, and that sort of built up. And so, they learned something over time just based on their own patient population.
I'm going to keep moving through a little bit. Tom had a question that all of us had, and we were talking with our South African friends as well. So Tom, if you'd pose that in a second. And then John and Paul, if you guys can see the screen, pick out some questions that you'd like to have at. Tom, would you go ahead? You're mute. You are still mute. kind of nice ones, Tom.
There we go.
Oh, there we go.
Actually, more of a comment, and it was John was talking about islands, and there's some very, very successful example of islands, and three of them I can come up with is we have a physiatrist in our organization, the head of the Italian side of PM&R, Germano Pastelli, and Pastelli has set up these islands all over, most successfully in the Balkans. And I visited his clinic, Meldano de Grippo in Shkodra, Albania. He's also been to Montenegro, all over these very low resource places, setting up PM&R islands and getting fellowships, bringing people to Italy and training them. Another one is the Pakistan Army. We have a guy in our organization, Farouk Rathrour, and the Army is looking for data. I mean, the Army's got tons of data and they've got tons of patients, and every country's got an Army. And so that's definitely a resource you can go to. I think the most successful example of one of these islands is Bangladesh, where one single PM&R doctor came out of World War II in a very, similar low resource environment to many of the places where you guys are from. And they built this enormous PM&R society. They've got over 125 PM&R docs in Bangladesh. So these are, you start with an island and you build it. And it's there's some very, very successful models to follow.
So just a couple of comments on Paul's approach. Number one, he was mentioning looking at the global statistics in the country and being able to try to project, or even a subset of the country, which is a good idea. And actually, every country is required to submit a lot of data to the WHO using the ICD, which should make that kind of data available for that purpose. The second comment I'd make is that at least within the World Health Organization framework, they would like to see the data systems that measure progress of individual patients, and then sometimes aggravated for countrywide data, to follow the International Classification of Disability Health and I'm blocking on the last word, but the ICD, and to report it within the categories of the ICD, so that there would be a possibility of comparisons, not just within the individual facility, but then among facilities within a given area, or even among countries. So there's an interest in trying to keep things standardized. So I was going to take one of the easy questions, Andy. Is that all right? You're on mute.
You're mute.
Yes, please go do what it's time for you guys to just field what you think is cool to talk about.
What did the first PM&R conferences look like, and who attended? Well, fortunately, I was at the first conference of the International Society, but by then we'd been in business for a long time. I'm not sure that counts. There were two international organizations, the International Federation of PM&R and the International Rehabilitation Medicine Association. And when they first met, they were very similar probably to our current organizational meetings, except they were much smaller. And but actually most of the issues of rehabilitation have not been resolved. And so the same kind of topics that we've been dealing with currently probably were discussed at them.
Gentlemen, pick a question.
So I'll there are a couple on relating to the private sector, some low-hanging sectors for private sector companies to get involved, the factors that determine which for-profit partner for a long-term sustainable relationship. So I'll go back to some of the stuff I was talking about before. When we were trying to start one up in Uganda, we did very explicitly approach companies trying to identify the potential payers. Who is it? So we started with a value. Who is it that rehabilitation brings value to? Who could pay for it? And it's admittedly not going to serve the entire population. But the thinking was, if you start with this, then you can expand to try to serve more and more with the population. But if you're thinking about it from generating private funding to get going, then you have to start with a group that can pay for it. And companies with large numbers of employees seem like an inviting place to start, even in countries where there isn't some sort of insurance. So insurance has started taking hold in Kenya to some extent and some other places, but still it's a lot of out-of-pocket expenditures. So you go to the companies to identify which have a large number of employees, and it's probably those where the work requires a lot of physical exercise of some sort. Another area that I would highlight on this, though, and something that we're working on at University of Michigan, is products that are associated with it. There is a challenge group that we just started up here that's university-wide that is trying to take first of all, develop technologies that could be useful in these settings. It's in healthcare in general, but the first one we're focused on is in rehabilitation, in the area of rehabilitation in Ghana, actually. And maybe we might try to extend it to India as well. But the thinking there is you've got a lot of trying to combine the technologies and the thought process that are coming out of classes. There's a lot of research and there's a lot of student work that's being done on technology development for specific healthcare needs in lower resource settings, and combining that with a local company to make it commercializable. So we think there is a possibility to develop a company that would be distributing equipment that could be used in rehabilitation as a way to start serving this this segment of healthcare and do it profitably. And again, there's an example that I have in mind. If I go back to Arvid Eye Care, they started up a company called Aro Labs that manufactures intraocular lenses, which are used in cataract surgery. The intraocular lenses cost in Western markets upwards of $150, and they initially had the price down at about $5, and it's dropped since then to just a little over $1. The cost and the price they were charging has been no more than $10 at any time. So they dramatically dropped the cost of it through their technological improvements in the process. Not the lens itself wasn't any better, but it wasn't any worse either. It was just as good as that being sold in Western markets. And that was done a few decades ago, but today it's a global competitor. It sells in Europe, it sells all over the world, and they're competing with the largest companies out there, not because they were trying to, but because they were trying to develop initially for their application, and then it could sell elsewhere. So I see that in general as healthcare as a real opportunity, because the low resource settings, the growth in expenditures in low and middle income countries on healthcare has gone up 3 times as fast as it has in high income countries. That presents a significant market opportunity for companies that are out there. And most of the multinationals can't figure out how to do that profitably. If there's a company in one of these countries, or if you wanted to start something up in conjunction with your hospital or something, and you can figure out how to successfully serve the markets you're working in, there's no reason that product couldn't turn around and start taking on a larger global share down the road. So I really see a significant amount of promise in this. And the nice thing about a lot of the equipment related to rehabilitation is you're not injecting it in someone, so the approval process wouldn't be as significant, and the barriers associated with the liability and whatnot would be significantly less as well. In addition to the servicing, I'd be thinking of products that might go along with that.
Well, folks, I'm going to try to be disciplined with this because I really want to lock you both in a room for 3 more months with us. So first off, John and Paul, you're great friends and great leaders and mentors, and I'm just so honored that you came to work with us and help us out today. There's a bunch of ears listening here who are true leaders for their countries all around Africa and around other parts of the world, and both the factoids, if you feel like you didn't give us enough factoids, the words and the fact that you're here with us really helps these folks to move forward and realize that these ideas need to be flushed out and that they can do it, that they've seen people, 2 very outstanding experts be successful in this. So to both of you, thank you so much. Miriam, one more thank you to you, because we wouldn't do it without. And IRF friends, we've never done fundraising. We've always just done it bootstrap, and we've got too many Africans to bring here, too many Americans and Europeans to bring over there. Tom's video is part of that effort in the US. So somebody said, is it just the US? No, he just made the video for the US. You all need to get to work on how you're going to help us raise funds to bring our friends back here and to have us, our other friends, go over there. And I'm going to turn it over to Miriam to get to some closing remarks and end things up. So thank you, everybody.
Andy, if I just want to thank you and Tom and Miriam, because I was really impressed with the way this was organized. I thought I participated in 2 or 3 of these even just the past few weeks, and this format I thought was really great. I really enjoyed it. So thank you all.
Thank you.
Miriam.
That's a Miriam production.
I second that.
Yeah.
Well, thank you everyone for virtually joining us. And again, thank you, Paul and John, for the generous sharing of your own experiences and inputs for building sustainable programs in low resource countries. It sounds like we have a lot to navigate and push through for advancing rehab practices through strong partnerships, whether it's a nonprofit or for-profit. And remember, guys, IRF is always open for you guys. And I feel like who we are is a glue to stick all this passionate catalyst together for making best team and collaborative force, because really, like, you can't make a change with just a single mind, right? We need to collectively work. So if you have not signed up to hear our updates or news or events, please do so. Visit our website, rehabforum.org/involve. We have just opened our Instagram account as well, so at rehabforum_org. Also join us through Facebook. And also we have a campaign coming up on a National Doctors Day, which is March 30th. That's next Tuesday. On this day, we want to honor the Africa Fellows and our colleagues that are all over the world who are pioneering ways to build PNMR in their country. We're raising funds to support these pioneers with more opportunities and experiences, like seeing the best practices of PNMR teams, receiving rigorous hands-on trainings, traveling to meet international PNMR communities, and more. So we need your help to join this challenge on Doctors Day to rally your awesome force of supporters around you, whether they're your department staff, your friends and family, to really raise awareness about what PNMR is and how important it is to get the universal access to this, this specialty. And if you're really interested, please email me at irfoffice@gmail.com. If you have not done any fundraising, or if you don't have any time to do it, don't worry, we will support every step of the way, and we'll provide you with ideas, resources, fundraising packs, and even local partnerships with the restaurants or other local businesses that will be willing to help you guys out. So thank you all again. We're gonna play Tom's video once again. And then, I'm going to send out an email out to you guys for doing a follow-up survey about our event today. But we'll do more of this again in the future. So thank you guys so much for joining us. And this is it. And if you have already watched this video, you guys, you may leave the meeting. I'll be in touch with you again through emails. Thank you guys so much.